Hi friends, today we will be discussing something related to ops on how to plan the paper accordingly so that uh, there is no confusion or there is no disturbance while studying the paper. Disturbance in the sense I mean to say that you won't fall it in a clutter market or where there are a lot of portions and you forget what is important. Okay, this is the basic outline on how to plan your all ops. So if you see, I'm sure you would have, even if you have watched the video, you can watch it for this fact that I wanted to emphasize more here on how to plan it. There I have even explained things of other topics, though many would have not watched the major part. But here focus is given on how to plan it. Okay, so here these are the five things which they expect us to know on. Okay, so this is part 1, 2, 3, 4 and 5. Okay, so basically what I wanted to convey here is that part 1, part 4 and 5 is like later. What do you mean by later? In the sense that, see, here you will get 6 question and here you will get 6 question. Now we will plan our study our day before exam accordingly so that these things you can cover it off, because here the major thing is what, it's a neonatology code, correct? Plus in purpurium, what you will get purpurium, that is you might get about sepsis and pyrexia. And here in one more important thing is about FGR, which is one of which you might get as one of the important question. And here you have only 2 chapters. Okay, I am not sure. Okay, only and that too they will ask you about the steps or something related to that or forensic related part. So here in this video, what we'll be doing is that we'll see which topics to be covered first in part 2 and part 3 itself. Okay, so though here I have just mentioned you about showing up the things which are important, having a general template for a particular section in a particular topic is something which is important. Okay, so that's what we will be dealing here today. So again, you would have seen this already. So this is part 2, which contains almost like 3, 4, 5, 6, 7, 8, 9, 10. Okay, so out of this you'll be getting almost like 6 questions. That's what they're saying. See, so if you see this part, this is the most high yield, right? So here we will see what is the major things which they have to say. Okay, see, first let me be very clear. Ops is more of flow charts and numbers. So a good grip on all these things is required. So if you go through that, there are a lot of flow charts. So here the emphasis is given on the thing that where which flow chart you have to concentrate. Okay, so again, this is something, these three are something which I think even if you read once you remember, then this is something which is your core clinical thing, correct? Everyone would have seen this and everyone would have heard about the management, so I am not keeping it as an important. I mean to say something which is not, which even if you read on the last day should be enough, but these are the things where you need to invest little time so that you can manage off things. And here what they're asking about the CS cervix management in an obstetrical case, so obviously go with the classical section. That's something which you know. Okay, I'm not talking about that part, but we'll focus on this thing and we'll see how to form a general template for second part of a obstetric. Okay, so here what is the major thing is that one, you will get about hemorrhage in pre-pregnancy. So whenever bleeding is happening in the pregnancy, classify whether it's a 20 weeks, if it's less than 20 weeks or if it's more than 20 weeks. If it's a less than 20 weeks, then you have only 2 to 3 differences in your mind: abortion, GTN. Okay, but if it's more than 20 weeks or 22 weeks, okay, this is what is called as APH. And again, if it's coming from mother or fetus, you have to determine. Then again, you might have 2 to 3 cause, that is placenta previa, abruptio placentae, and if it's coming from the fetus, then it's obviously a vasa previa. Okay, then so here again with blood, again, even if it's happening during delivery or after delivery, it's called postpartum hemorrhage. Okay, so what is the main core here? Management. Okay, so what is the major thing which is common to everything here? That is the emergency management of it, which is A, B, C. Then look for hemorrhage, then order CBC, then check for blood group, then order PT-INR to check whether the patient is going into DIC. Then again specific indications, again you have to check here. If it's in this case, what you do here in this case, again you have to check where the blood is coming from, whether the blood is coming from the mother or whether the blood is coming from the fetus, correct? So based on that, again you have to ensure whether the baby is stable or not. If it's assuring, then you can just leave it at that part. But again, if it's not assuring, what will you do? Again, if it's not assuring, again you will go back and uh, uh, terminate, or you will give an antenatal steroid by time by using tocolytics. Then again you deliver. Correct. So this is one general idea related to bleeding. So if you have this differentials in your mind and based on your duration, again you have few differentials. Again you can plan your management accordingly by writing an answer. But what is the, and obviously about PPH I will discuss about that part in the same flowchart itself. But this is what one of the core which I wanted to say. Again, one more important thing which I wanted to say is that, so I hope this is clear about the bleeding. And here the major emphasis is given on the fact of the pregnancy, that is ectopic pregnancy thing itself, that is early hemorrhage ka cause. Okay, one more important thing which I wanted to say is, that is one thing. Okay, so again this is something which we have done. Okay, but here comparing that with GTN. Okay, GTN abortion, especially GTN and ectopic pregnancy, not ectopic pregnancy as such, but that two topics come hand to hand. So make sure while doing that thing, no, you cover that part also. But while if you want to study in an whole, no, then you can combine this, and again in this part again you can cover the PPH part also. So these two also goes in hand in hand. This is what I wanted to emphasize. So after you studied 16, it's better if you go and do the 19th part also. Okay, that's one more thing. Then again, about the management, right? So whenever you are doing an intrapartum care, so for example, that's why I will be discussing first about preterm labor. Okay, again you know about the preterm labor also. You have early preterm, late preterm, all those things, that is fine. But what here I wanted to emphasize on the fact that whenever you are delivering, for example, you are writing a management protocol, make sure while writing that if it's a less than 32 weeks, obviously you will add MaxSelf. If it's less than 34 weeks, again you will give corticosteroids. Though now ACOG recommends even after 34 weeks also it's better to give, but let us follow Indian guidelines, and you can just write plus or minus. But less than 34, you should give corticosteroids. Again, if it's more than 34, it's left with the clinician what they wanted to do. So again, this is the broader overview. Again, you can do, if it's a preterm labor, obviously you can go for GBS prophylaxis also. For that, which you need to do a culture and sensitivity with the swab. Okay, so that is one question, that is about antibiotics prophylaxis also you can write about it. So this is where I will share you where this is going to be useful. For example, while writing, again this is one of the overview which you have. So again, if there is a fetal or maternal compromise, then you obviously, this is the major thing which you have to mention, that correct, if it's you have to see for the gestation, then we have to buy the time if it's less than 34, because it needs 48 hours to produce that surfactant. So for that, again, what is the important thing which I missed, that is tocolytics also. So less than 34 weeks, obviously also have to use tocolytic, that is nifedipine, which is commonly used, and you buy the time, and so that it is stabilized, then you can manage it accordingly. Correct. So this is one of the general overview which you need to have. Correct. So again, one more important thing is, if there is no complication, you obviously deliver at 39 weeks. If there are little complication, you will deliver at 37 weeks. Okay, that is one basic overview which I want you to remember before starting anything in ops, especially while writing the management protocol. Anywhere and everywhere, even if you are writing this, you can write. But one thing, especially in preeclampsia, which is the cure, that is termination of pregnancy irrespective of gestational age. So basic things, if you remember, then obviously it will be easy for you, so that you don't get stuck, because at the end the learning has to be nice. Correct. So that is the main aim of the video. Correct. So again, let me give an overview of everything, and so that you can study accordingly. Okay, now okay, so again, next important thing which I wanted to discuss about is about the multifetal gestation and idomnias, especially the idomnias part. That will have a flowchart also, that will be dealt in detail. Then medical and surgical disorders, there are a lot of things, but important things I've included so that you don't forget the rest of it. And also hypertension disorder, one question is almost like sure from this part. Okay, so now based on, after that we can come to labor. So what I would say is, again, while doing, before you do part 2 of obstetrics, doing part 3 of labor, especially the management of preterm, will give you a broader overview of writing a management protocols for all the parts of your medical surgical disorders, APH, and all those things. So that's why I explained that 32, 34, and also the swab things, and also the tocolytics to buy those time. So that is the importance of knowing what to study at what time, which part to study, which lesson to study at what time. That is what is the major core which I wanted you to understand. Again, while starting the part 3 of it, so major important thing is again, there are few things which are like core which I want you to know important things. For example, again 23 chapter is important, 26 is important, 28 is important, 35 is important, 37 is important, 22 and 30 and 27. Okay, these are core. So let us see which are those things. Again, 23 is important. Okay, 26, 28. Okay, 26, 28, and again 35, 37. So these two, and 22 and 27 with 13. With 13, yeah. So how do you plan this? Says, for example, even before studying the part 2, finish off this part. Okay, this is something which you need to finish first. Then I hope at this point of time everybody would have known what is labor, but again you can study this part first, then come to the complicated pregnancy thing, then study after knowing what do you mean by complicated pregnancy, obviously, which is the major important thing which you can study. One is about how do you do that, that is the complicated labor, and what are the other things. Even if you don't want to do that, I would recommend you to do this with this. Okay, after completing normal labor, it will be ideal if you study even the complications of all stages of labor, though the important stage which there are complication is third stage, where you do AMTSL to prevent PPH, correct? No, so you can compare this with this, you can combine this with this and finish it off. That is one important thing which I want to say. And again, all these three is something which is not core obstetrics, but important to know, because that's how you manage obstetrics, correct? Especially induction of labor, all those pieces of score, and important BPP on how do you modify, on how do you monitor, and also pharmacotherapeutics and obstetrics. All those things are important. Operative, again, I have not dwelt in much because of the fact you need to go back and check. Okay, again, perineal trace, please draw the diagram which is there in that. I have not found it in my. Okay, so that's what other important things, and remaining all these things again. No, sorry, these things. Here again, dystocia is important. Okay, so that's how plan it accordingly and go about it. Okay, this is what I wanted to say about it. And again, I'll discuss a few important protocols or management things which is given in Datta. Again, what I would recommend you to do is go to this, study this. But again, while before studying, I know you have a 3 days gap, correct? So when you have a 3 days gap for obstetric itself, that's left to you. How do you plan? But what I would do is, first, if you want to study, you can study Gynec, but Gynec has very easy narration, though the topics look big, but when you start doing it, you have only 2 extra things which you need to study, as I'm saying from that day itself. One is infertility and urogynecology, and there are fixed questions in that, correct? So you can study Gynec for 1 day, that's left to you. But again, while doing, at least I'll give you a 2-day plan. What you can do is, 1 day, what you can do is study the management, because management protocol is something which is pivotal and you should know. 1 day you can compare this with Maro. Okay, here Datta has given you something, but if you need to understand Datta, what Datta has given, I would recommend you to watch all the management videos. For example, there is a video for preterm labor itself. For example, think that it's a video of 50-60 minutes. But what is important for you is the management protocol of the preterm labor, which would last only for 20 minutes. And even if you see in 2x, you will understand, because you would have already studied. So 1 day you can do that of the protocols which I'm giving you now, and then study this part, so that all your 10 markers and 5 markers are set. Then the remaining part 1, part 3, part 4 and part 5, you can deal on however you want. That's left to you. But I don't want you to miss on 10 markers and 5 markers, because those are the core to pass. Okay, so these are the important things. Again, how do you do? Again, management of preterm labor, always you have to write about the aims. Again, based on how do you do that, based on what is the important component which is getting affected, you need to write the aims. Then you need to do a proper assessment also. Again, why is this they are divided into 34 weeks, again, to know what are the drugs we have to give. Again, whether it's early preterm or a late preterm is also something which you need to understand here as well. Again, I have also explained you the fact that why all these tests are being done. Again, why even before managing, you have to diagnose things. So these are the important things which you need to diagnose. For diagnosis, again, you have a clinical diagnosis, or again, you might have a ultrasonical based diagnosis, or again, you might have a fetal fibronectin based, that is investigation based diagnosis. So you can diagnose preterm labor in a three ways: either clinically diagnosed based on this protocol. Again, you might have investigation based diagnosis based on fetal fibronectin. Again, ultrasound based diagnosis is based on this. So, though clinical diagnosis is the mainstream, correct, because that's what you also, so per specular examination you would see that if it's there, then PTM is likely, see the protocol how it is going, then obviously you need to manage the things accordingly. But if it's less than 3 centimeter, that's about the cervical dilatation, then obviously you go with the investigation and scanning which you would do. And obviously go, what is the whether it's a non-invasive test which you can do is the cervical length measurement. So based on that, you, again, if it's a if the cervical length is less, because you always know that it's a T-shaped, U-shaped, V-shaped and Y-shaped, which you would have already knows, then again if it's getting less, obviously there is a likely chance that it's a preterm labor. But if it's not there, then obviously that's the point where you can pick up the fetal fibronectin scan, or sorry, investigation, and you can do that. But again, if the cervical length itself is more, then there's no point of thinking about preterm labor, but you can admit the patient and you can observe it for 9 to 10 hours. Correct, this is how it goes. So I hope I am giving you the overall gist of the management protocol so that you don't get confused a day before exam and you can manage it accordingly. Then again, if it's more than 34 weeks, then you did an assessment, and if there is if the cervical dilatation is more than 3 if it's going up to the if it's a progressive cervical dilation, obviously you need to go for delivery. Okay, that's one important thing which I wanted to take about. Again, see that whatever I've explained here, same thing has come. So that's the importance of knowing, understanding things generally, and then putting those into the flowcharts which are there. So I hope preterm labor is quite, I made things easy, at least in that part. Then again, intrauterine fetal death. So what you do, that's I will just give you the gist. So basically, even if you do nothing, there are high chances that it might go for a spontaneous expulsion. Okay, that's the important thing, and you can see that 80% of the conception will be expelled spontaneously within 7 to 10 days. But what is the major important thing is about the psychological factor and also the counseling which you need to address upon. So based on things, if patient is willing for an early evacuation, then obviously you need to go ahead and do that. For that which you need to do an hospitalization. Correct. So based on that, again, what you are going to do is that you will admit the patient, then you will obviously, you have to check whether the cervix is, is the important thing is we have to check whether cervix is favorable or not favorable. And again, if it's unfavorable, what is the important thing which you need to do is, again, you have to try making it favorable again. So that's what they are trying to say you. Again, how do you make cervix favorable? By again giving this misoprostol tablet. Okay, so again, when you give, if it's favorable, obviously start with oxytocin infusion, then deliver the baby. Again, if it's not having next, if you are unable to do that, again you can increase the prostaglandin supplementation also, that is intrarectally, intrarectal is how you will do, or intravaginally. Again, if it's not favorable, again you will do it again and again and again. That's what they're saying. See, every 4 hours, and also cerviprime cells, which is used for augmentation also. Then again, if it's failing, then obviously you have to supplement this with oxytocin at the end. Correct. See, obviously will deliver the baby, and also you have to do an autopsy study for the cause of knowing what is the cause of going for IUF. Okay. Though this is not important, I just wanted to make sure that you know that. Then RH negative, it's like a short 10 or 5 marker question. So again, what is the important thing is if you know the genotype of father. See, if the genotype of father is, for example, is not, for example, it's an RH negative mother. Okay, whenever so the importance is knowing about the father. If the father is RH negative, that for example O negative or something, then it's just stupidity if you go and write all your management protocols. So though they will not give you, but it's what is the importance of me saying that is you have to mention about this. Okay, that is these two things. Mother being RH negative and father being RH positive is an important thing which you have to mention. Without that, even if you write everything with every numbers, there is no point in giving marks. Okay, so be very clear. Okay, even the ulta is not true. For example, a mother being RH positive and father being RH negative, nothing will happen. Okay, so that's what the importance of knowing it. Okay, then again you will obviously do a whether try to know the genotype, whether it's homozygous or heterozygous. Then what is the major important thing is, so first step what you have to do is to check whether mother is sensitized. Then if she's sensitized, then you will check to what extent she is sensitized by doing an antibody assay. Then you look for complications. That is what fetal anemia. But that too, how do you look for a complication? First, always by doing what you do, a non-invasive test. Correct. 1 second. What happened? Okay. What you will do, a non-invasive part, that is MCA. And if it's positive, obviously you go and do it chordosynthesis, that to give blood. So I hope this gist is very clear. So based on this, let us see what they are going to say. See again, this major, that is one important thing about knowing the category of it is important. Then obviously you will check whether she is sensitized or not sensitized. And again, if she is not sensitized, what is the major aim of you to, what is the major role of a duty doctor there is to prevent the further sensitization by giving an uh, by giving an Rogam injection, correct? So again, if the antibodies are already present, then you have to check for the titers. And again, based on titers, if it's positive, then obviously what you're going to obviously check for fetal anemia by middle cerebral artery peak systolic velocity. Again, if the fetus is having problem, then obviously you will check what is the gestational age of fetus. Then based on that, either you can go with intrauterine fetal transfusion by checking hematocrit. That is the major thing. Then based on that, you can either go for again, if the hematocrit is very low, then obviously you have to go and start the infusion. Then if check the fetal lung maturity and deliver. Okay, that is one important thing which you need to understand. So again, I hope I am clear. First, knowing the diagnosis part, then you have to check the uh, whether she is exposed, that is whether she has been sensitized. Okay, that is one important thing. Then if she is not sensitized, the major thing is for you to prevent the further sensitization by giving an injection. But if she is already sensitized, then obviously you have to check for complication. How do you check? By we first using a non-invasive test like MCA, Doppler. And again, if it's positive, obviously you will go with hematocrit or chordosynthesis. Clear? I hope it's clear. Then again, management of breech presentation. Again, the major important thing what they are trying to expect here is that how do you, so again, based on what is the presentation, based on how do you go about it. Okay, well, if it's less than 36 weeks with consent, obviously you do an ECV. But again, if it's more than 38 weeks, it's obviously better to go for elective C-section. But though nowadays, obviously you take a nice consent and go for C-section. That's what is being emphasized or is mostly being done nowadays. But again, if you have a chance, obviously you try for an external cephalic version. Make sure this is something which is important. Again, this is also important. Okay, obviously if it's successfully delivered as vertex, then excellent, very good. But what if it fails? Again, you have to try for an elective trial of vaginal delivery and vaginal breech delivery. Again, you have all those maneuvers which you obviously while doing that maneuvers, there are three things which you need to deliver. That is three important construction orders: buttocks, neck, and the head. So based on that, you have different maneuvers to do that. So place it accordingly and come back. Okay. So again, there's nothing much for me to explain in this part. Okay. Then obviously this shoulder dystocia helper mnemonic, which is important. Though but there's no flowchart in that, I would request you to just go and check out the MAR explanation of the management part. That is what is my important message in this video. Okay, then again true PPH. Again, what are the 4 T's of PPH? I think in and out of PPH you would have known at this point of time, because I don't know how many times you would have studied. Again, 4 T's are that trauma, then tissue, that is placenta, then thrombin, and atonic, which is the first most common, that is atonic PPH. So basically there is no tone, correct? So what is the major thing is obviously first is about the emergency management, and based on that again you have to try. Again, if it's a traumatic, then you obviously do the suture and come back. But again, how is this basically going is that first you obviously go with uh, medical management, that or you give all these drugs. Then if it's failing, then you do the tamponading effect. Then if it's failing, then you go for artery ligation. Then if everything is failing, then obviously go for hysterectomy. So this is the core idea. So based on having this core idea in mind, then let us go and see what they are trying to say about it. Okay, again, though this might look very big, there's nothing except I would not request you to or expect you to write everything also. Again, basically, see, all this ingestion is what I told. Then again, tamponading, that is mechanical. Then again, one more important thing is before going for artery embolization, obviously you can also go with sutures, that is Behling sutures also. That is also one more thing which you can. Then again, this is the last part. So you know the general gist of it. Now you study about the drugs, then you study about how do you go for about balloon tamponading or by manual compression, so that you know how to go about it in further grow also. And again, this FGR is one more important topics which you need to study under neonatology section. Okay, this is one core obstetrics part which is there in in part 4 of our obstetric part. So again, you need to do a diagnosis itself, because majority of the case will be something related to physiological. That means I mean to say that if dancing SGA, what do you say, again it's because of parents itself, though the parents being short, all those things are very common. So making an ultrasound based diagnosis is something which is pivotal here. Okay, so based on that, and obviously if it's there, again I told you, if there is no complication, then obviously you deliver at 39 weeks. But again, if there are some complication, obviously you do at 37 weeks. Then again, if it's less than 37 weeks, then obviously you have to check for a Doppler study, because that's one of the non-invasive thing. Then again, if there's nothing, what do? You deliver at 39 weeks. See, that's why knowing the common, I mean to say the basics is important. No complications in delivery, in pregnancy, 39. Slightly some complication, 37. Okay, then if there are some, if there is something beyond that, then obviously buy time, give steroids. How do you buy time? Tocolytics. What do you do? Steroids. If it's less than 32 weeks, give magnesium sulfate so that it has a neuroprotective action. Then again, you are worried about infection, then check for GBS prophylaxis and give antibiotics also. That's what the important thing. And what if that is what I wanted to emphasize on this video, so that you don't feel that stress. Because I know obstetric is more of flowcharts and numbers, but when you give a general overview of the topic, you should not be stressed about numbers. Even if you miss out few numbers, it should be fine, provided you know these basic numbers in mind. That is what I wanted to say. Okay, so again, what if it's an abnormal umbilical artery Doppler? This is what again it can be based on. Again, you see, if it's an RDV, what do you do? Obviously, you have to deliver as soon as possible. See, again here, that is what this given. Again, based on how is the blood flow, you are going to deliver the baby accordingly. Okay, so based on that, you will manage it accordingly. So I think that part is clear. See, again, 34, 30 and 26 to 30, provided you also need to talk about this. Also, you need to talk about this. Also, one more thing which you need to talk is about the antibiotic prophylaxis, that is GBS if it's required. Okay, so this is the basic outline overview which I wanted you to know. Okay, then again, schematic management of tubal ectopic pregnancy is something. It has to be studied, and this has to be studied under what? This has to be studied with or with conjunction with something called as GTM. So what is that important thing is why they have mentioned to be ectopic minded is because if you lose the patient at that point of time, then you will not lose one patient, but you will lose two. That is, though ectopic pregnancies cannot be continued, you will also lose the mother, is what I mean to say. So what is the two numbers which you need to mention, need to remember is 2500 and 6200 or 6000. Okay, I'm not sure, please go check. So based on this is for TBS. So this is for transabdominal. So at this cutoff, you need to see a gestational sac. But if you are not seeing it, then it's something abnormal. So then you have to think about ectopic pregnancy is what I mean to say. These two numbers, but then how do you monitor the beta HCG? So based on your beta HCG monitoring, and these two numbers should determine the flow chart. So again, based on that, again, if it's negative, then there's nothing. Then if there are some clinical features, then again, again, if there are again 1500, I think it's 1500 to 2000, I'm sorry. Okay, so again, based on that, if there are some if you are again not seeing that, okay, intrauterine sac is, if it's visible, then it's a normal pregnancy. So first part is about no pregnancy, then about normal pregnancy, then again, if it's there, now it's coming about the adnexal mass. Okay, then it's about unruptured tubal ectopic pregnancies. Okay, now based on that, okay, now you know there's something, now it's not in the now it's not in the uterus. So based on that, obviously you have three things which you can do. One thing is that you can do medical management, you can do expectant management, and one more is surgical, which is the major thing which they do is medical management. Expectant is that you are expecting that it's not likely an ectopic and something else. Then that is the important thing. That means there should be no cardiac activity, there should be no evidence of bleeding or rupture, something which you should know. Then what is the major thing in medical is that you have to start on methotrexate. Okay, how do you start? Again, here you will give a single dose, but what you do in GTN, that's a multiple dose. That is day 1, 3, 7, 9, you give methotrexate, and alternative day you give folinic acid, and you have to monitor the beta HCG's falling value. Correct? That's what you do in GTN. That's why I told you to compare this with GTN, then plan the proper overall management. Then again, this is the major thing which they wanted to do. Now again, surgery is, major indication of surgery is that ruptured, and one more thing is that failed medical. When you say it's a failed medical, when this is not being followed, that means the methotrexate is not falling even after 3 times. So that's when you can go with this thing. So though this is the major things based on the family thing and family planning, if it's not done, if she wish to have future kids, then obviously one more important thing which is given is linear salpingostomy, where you again don't do a suturing, because again you should not precipitate ectopic. So that's what, again, knowing these things is fine, but again revise it a day before exam. What's that management part of ectopic pregnancy in marrow itself, because you have 3 days time, so that you don't forget. That's what I wanted to say. Okay, then again, twins during labor, again, how do you deliver it? That's basically intrapartum feeder. Again, it's a vertex presentation, or how do you go about this? That obviously you go and deliver based on what is the lie. Again, you have to check for the second baby. So based on the second baby presentation, you need to manage it accordingly. So again, if it's a transverse lie, obviously you do an internal potalic version and you try to deliver the baby. Otherwise, if it's a longitudinal lie, then obviously try to get it into vertex, or you can do either a breech delivery using assisted breech. And if it's an high, if it's still high, then you use forceps. Again, if it's a low, then obviously you can go with venous delivery. Okay. Sorry, if it's a night, obviously you go for venous delivery, but if it's a low line, then you can obviously put that forceps and get it back, because that's why you need to know the instruments properly. Again, if you see, the venous is something long, but forceps is something less short, very less lengthy. So based on that, you study it accordingly. Then again, chronic polyhydramnios, I don't think this is not that important also, just I mentioned so that you know it also. Again, make sure preeclampsia is different, eclampsia itself is different. So this part is also important. Again, based on when do you get eclampsia, you need to manage it accordingly. Okay, that's what important thing which I wanted to say. Then again, APH are given you an overview on how to go about it, the bleeding disorders, because that's one important concern which all the obstetrician has, because that's one of the core emergencies which you need to treat about it. Then based on your diagnosis, you need to plan your management accordingly. That's what is the important thing which they are going to say in this part. Then again, abruptio is also some part of the same part of it, so don't worry much on it. Given proper important part on it. Then again, while doing this part, I would recommend you to not to write this part, okay? Because again, they will usually ask about iron deficiency anemia itself. I would recommend you to study the marrow part of it, so that it's quite clear in what they're saying. The major thing which they search here is this. Okay, when do you give oral, when do you give parenteral, and when do you give blood transfusion? That's what an important core which they are trying to test you. Again, the major important thing is when you are near, when the delivery dates are near, you have to have the blood. So either you give parenteral or blood transfusion based on the patient thing. Again, if it's severe, obviously you have anywhere, anytime you have to give blood transfusion. That's the core. Again, these are the part 4, okay, the lactational part and all those things. So this I have again explained, that is the FGR part which you need to study, and these are the important other things which you also need to study. Again, you have two things: normal purpura, though they might not ask, but something related to PSM might come. But abnormalities of purpura is basically they are asking about pyrexia and sepsis. Okay, that's the two important things. Though psychosis can be asked, but again, that's already discussed in medicine. I don't think they will ask that. And here the term newborn infant, there are nothing much question. Again, this is the core core PSM part itself. Again, these are the basics, that is part 1 of it. Again, there are no RS question, there are no RS question. Again, here also there are no RS questions which are asked. So basically these are the 3 important topics which you need to know in and out. Again, diagnosis of pregnancy, this last day you have to revise. Okay, this is something which you need to revise last day, because again you have Jacquemus sign, Chadwick sign, all those signs things. So remember 3, because again if you don't know anything, again you can write confirmatory sign, probable sign, again nausea, vomiting, and etc. Correct. So that's how you plan your study smartly. Okay, then again the fetus, I think they are talking about the live presentation, attitude, all those things. Then in fetus in utero and fetal maternal pelvis is something if they want to ask, again I feel these are RS2 type of question, but if they want to ask, they will definitely ask. Make sure you study that part accordingly also. So based on this, if you see now and if you can understand the paper prediction, so you can see that as I have told you, part 2 and part 3 will constitute a major important part, and major important questions will be asked from part 2 and part 3 itself. So though 2 10 marker I'm sure will come from these 2 parts. Again, what are the things which they might ask is, again I have not discussed about GDM there, but make sure you should study GDM either or for a 10 marker or 5 marker will come. Again, these are the other probable questions which can come for a 10 marker itself, and these are the questions which they can ask for your labor part. Again, here what I mean that 2 questions related to one will come. Then again someone had again, what do you mean by labor related things? I mean to say the fact that again I have not mentioned about PPH, though here I have mentioned again PPH, AMPSL, okay, then again breech delivery, okay, then again preterm labor. There are a lot of questions here. The important thing is you should know all the flowcharts which are given you in the above part, and also few important things which you feel are important, you can revise that part also. Then again this is something which is like core, and please don't forget this topic, though I have not included here. This is one of the core competency which they are allowed to test always. Okay, make sure you study that part also. Then anatomy physiology related question, I mean to say that part 1, okay, this is nothing but the part 1 of the thing which they expect you to do. Then newborn related things, again this, or they might ask you even about FGR, that is fetal growth restriction, also being a core topic. Again, if you see labor related things, again if I mentioned here, again if you see, you can see that labor related things is only thrice or something was the problem. See, again when I mean to say labor related things, again some topics itself is overlapped with labor and medical disorder. For example, if you take about RH negative pregnancy, though it comes under medical disorder itself, but it includes the management part, includes even the labor part, as well as the proper maintenance on how do you do an antenatal care. So that's what I mean to say. So make sure you study that part. Again, what is, and 3 markers I don't want to discuss again, because what is the major important thing of a 3 marker in a surgical topic is that one question they will test you about your instruments or surgical topic, that is the core obstetrical part, something related to episiotomy or something related to C-section is something which they allow to test upon. So any surgical topic you should know something related to instruments and also something related to surgical procedure, is what I have told you from very long time, and that's what is being followed also. Then again, these 2 things, something pharmacotherapeutic, either they might ask you even for 5 markers also, but something core cannot be asked for, because there are a lot of things which can be asked for 5 markers. So I included in under 3 markers itself, but see, 3 markers itself, as I told, might not be predictable, but what is the major core of us was to predict the 60 marks, so that either you get 40 to 50 marks there itself. Then also the remaining 3 marks, even if you don't know anything, if you write something, they will give you some at least for 30 marks you'll get 10-15 marks, so that you will pass. That's the core idea which I wanted to discuss. But major things which I got got to know, or even I face difficulties knowing few things, especially that how do you remember those numbers and how do you remember those flowchart. So the major important aim of this video, though I will not do for any of it, any of the other part, is to have a general overall template for a part of a section. For example, even for gynecology, I would like to do that. See, for example, gynec has 5 sections. Again, 2 sections which I told are is something which you need to study extra. For example, if you are taking a malignancy part, obviously for well, let us discuss in the next part also, but here I'm just giving you an overview. So obviously malignancy, you can divide the overall clinical features into what: local, systemic, pressure related, metastasis related. Then again come to clinical sense and come to complication part. Then again, while writing the treatment part also, we should mention about prevention. Prevention without management is absolute nonsense for a MBBS graduate, because of the fact that as a primary MBBS doctor, the major aim of a clinician itself is to prevent disease, correct? That's why the core important part of a overall MBBS curriculum, if you say, it's PSM, that is preventive and social medicine. So writing about prevention in any part of any answer is something which is pivotal for 10 out of 5 marker. That's what it is, the major aim they are testing on. Though the management is something which you have to know in and out, but if you write prevention, you will get extra 1 or 2 marks, is what I wanted to say. So those general template is what I would like to give you in a gynecology paper. But though that general template cannot given in an obstetrics, basically for part 2 and part 3, because of the fact that the management protocols, though the last part of management you can give, but the disease itself is something which is different. Correct? That's what makes an obstetric paper stand alone from the rest of the topics or the rest of the subject in final year. That is what I wanted to share with you. I hope this will give you, or this will add some value. Even if you are starting your obstetrics now, know that these are your topics which you need to study, so that you can plan it accordingly. Then you study things which are actually important and don't waste time on jack shit. For example, something related to prenatal, for example, take this itself, prenatal genetic counseling. What they might ask something, but you, with your AdCom knowledge, I'm sure you write something. That is not the core, correct? Though that is important as a counseling part, I do agree on that. But the important thing which you need to know is about APH, PPH. Then how do you manage labor, or for example GDMPH? All those things are core. So what I would say is that watch that management part of Maro video well in advance. That is 1 day or 2 days previous to exam, because you have time. Correct? So why do you want to waste it on something else? So then you can plan, then you can come and see data flowchart. If you want to follow the Maro flowchart is also enough according to me. So okay, so plan it accordingly so that you don't waste much time, and you don't remember all those rubbish numbers which are there. Remember numbers which are actually necessary and actually important to remember. Okay, that's the gist of the video which I wanted to convey. I hope I have done some justice to this video. Thank you.